encourage you to use your chest app, and hopefully you've done this before in this session, in other sessions. To where? To the world? So we'll try 4 questions at a time. Yes. How many slides you got? A lot? Okay. If we have time, let's go. That's the goal. I was going to say that. It depends on all of us. I'm sorry, what does it? Of course not. No, no. Of course. The three of us would say. Okay. Thank you. That's fine. Are you? So we still have a few minutes before we're going to start. I simply want to remind the new people that have arrived this is an audience response session. So if you go to your chest app, follow the directions here. And I guess if you're having problems, ask your neighbor for help. So I'd like to welcome you to session 10358, Pharmacotherapy and COPD, Clinical Uncertainties. Wait 2 more minutes.
Whatever you choose, sir, is your choice.
I think we'll get started just because people are here. And again, this is an audience response. I said this before. Please follow the instructions. If you're having trouble, talk to your neighbor. So our first speaker is Dr. Nick Hanania, and he's going to talk about LABA-LAMA. The plan is that each of us will talk, hopefully, less than 20 minutes, and we'll have time for questions, comments at the end.
Thank you, Don, for putting this session together. Good morning, everyone, and I realize some of you are standing, and I apologize for the space. So I was asked to talk about LABA-LAMA. This is an area that for you and us as clinicians, we face what should I do with patients with COPD who are symptomatic. The GOLD strategy has sort of focused on LABA-LAMAs and put that on top of their list based on some of the clinical trials. So I'm going to review with you. These are my disclosures. My objectives in the time I'm allotted is really to discuss the rationale. Why do we really need two long-acting bronchodilators? Is there evidence supporting the use of LABA-LAMA versus a monotherapy, or when it comes to another combination, LABA-ICS and COPD? And then hopefully I'll have time to discuss opportunities of de-escalation of ICS and what do we know, at least from the current literature, although this area is still of hot topic and debate. Just to remind ourselves with the grouping, this may change in the 2018 GOLD, but in the initial encounter of patients with COPD, we look at them in grade A, B, C, D, and the choice of therapy suggested by GOLD, as you see here, in patients who are symptomatic, the next step would be is to choose a LABA-LAMA. A LABA-ICS here, as you see, was a second in line in group C, but certainly ICS
Mouse is not showing.
is not showing. Okay. For people on the internet, the mouse will show. But anyway, so LABA-LAMA is certainly the choice, at least in the GOLD 2017 reiteration. LABA-ICS is a second choice in Group C, but certainly has a bigger role with triple therapy, as we will discuss later with Dr. Sethi. Well, in the United States and around the world, we have several and more to come LABA-LAMA fixed dose combinations. These are the ones that are available in different platforms, and whether dry powder, MDI, or SMI. Now, what's the rationale for using a LABA-LAMA? And in fact, there is some good pharmacologic rationale, and there are some in vitro data on muscles to show that there not only that there is a additive effect, but possibly a synergistic effect. So let's review where the receptors are. The beta-2 receptors are obviously on the epithelium of the smooth muscle cell membrane, and the M3 receptors is what the antimuscarinics block. And certainly blocking both activating beta-2 receptor and blocking M3 receptor may actually lead to a relaxation. In general, patients with COPD have higher cholinergic tone than normals, and certainly anticholinergics have been the standard of therapy for many years in COPD patients. But there is some crosstalk between these receptors, and there's some actually emerging data that suggests that there may be a synergistic effect. Mario Cassola and his group published several papers, at least in vitro or on human tracheal smooth muscles, looking at this phenomena. What do we know clinically? And this is not meant for you to look at each study separately, but I wanted to show you what's out there. And this is a meta-analysis published last year where they looked at lung function. And there's no question that adding both over one improves lung function. It doesn't take a big brain to understand that we're doing 2 bronchodilators versus 1. And there's no question that, as you see here, effect is positive on improving lung function. What about on symptoms? There are several. These are 2 examples, one recent from the Dynegito study looking at tiotropium or ladaterol versus tiotropium, looking at one symptom questionnaire, the CAT score. You can see there is definitely an additive effect of having 2 bronchodilators. Another one published on a different LABA/LAMA, looking at transitional dyspnea index, which looking at dyspnea, again, suggesting that when it comes to dyspnea, there's no question there is an additive effect of adding both together. There's actually more emerging evidence to show that there is a very good effect on improving, although singularly, if you look at the studies, these things cross the 1, but if you look at the cumulative effect, there's definitely an effect on improving exercise capacity compared to a single bronchodilator alone. So let me go to my first question. Symptom improvement with LABA/LAMA therapy is dependent on baseline symptom burden, is dependent on baseline lung function, is only seen in patients with emphysema, is similar to that seen with bronchodilator monotherapy. Can you please vote? Not sure what the N is here.
It doesn't matter, it doesn't
Okay,
matter.
doesn't matter. Yeah, actually 84% of you got it right. And this is depicted by many papers. This is a paper by Fernando Martinez, and it's you may see that the patients on LABA/LAMA versus placebo is shown in gray, and versus a monotherapy is shown in blue. And then this is the CAT score change, or the change in the actually SSGRQ. And this is the CAT score at baseline. And notice that patients with CAT score more than 20 tend to have the best response in improving quality of life with the LABA/LAMA when it compared to placebo, or even when it compared to a monotherapy. So there's no question that patients who are high symptom burden may benefit best from a LABA/LAMA. One other emerging interesting study was published this year is the CLAIM study, which actually looked beyond the lung function and symptom, and they looked at cardiovascular function. And we know hyperinflated patients, and that's what they enrolled in this study, have a problem with end-diastolic volume and probably cardiac dysfunction. And here they did measure these, and they looked at hyperinflation. This is the residual volume here after treatment versus the placebo. And this was a crossover study, but they also showed that a LAMA/LAMA can improve cardiovascular parameters, including end-diastolic volume and stroke volume index. So there may be some cardiovascular improvement with the LABA/LAMA. And this actually has been shown by several papers. This is a review paper from Jim Donahue, where they looked at the LABA/LAMA, and the better improvement in FEV1, the less the exacerbation. But not only that, but if you look at other symptom improvement, such as the baseline medication use and rescue medication, a LABA/LAMA shown here in purple has the better profile. Well, what about exacerbation? Here the data are not as strong, looking at tiotropium and ladaterol versus tiotropium alone. This was the Dynegito study published this year, actually, was a huge study, actually, that looked at exacerbation as the main endpoint. And when you look at the primary endpoint, which is moderate or severe exacerbation, which is shown here, even though the p-value is less than 0.05, and there's definitely a trend, the predetermined p-value to be significant was 0.01, so it did not meet the primary endpoint. It did have some effect, a significant effect on subgroups of patients on exacerbation. And naturally, a LABA/LAMA here did show a better effect on symptoms than other PROs, but the exacerbation effect was not statistically significant. Mind you, there were other smaller studies. This is a large, huge study, but smaller studies with other LABA/LAMAs that showed an effect on exacerbation. What about comparing a LABA/LAMA versus LABA-ICS? Well, we're talking about lung function, definitely looking at meta-analysis. This is by Rodrigo last year, in International Journal of COPD. Whether you look at it at 12 weeks or 26 weeks, there is a beneficial effect when you look at meta-analysis of studies published with the LABA-LAMA versus LABA-ICS on lung function. What about on exacerbation? Let's answer this question. The FLAME study, which examined or compared the LABA-LAMA versus LABA-ICS, demonstrated which one of these? 6% lower annual rate of exacerbation in the LABA-ICS treated compared to LABA-LAMA treated group. Effects of LABA-LAMA were more marked in patients with moderate airway obstruction. Effects of LABA-LAMA were more pronounced in patients who are not using ICS at baseline. There was 11% lower annual rate of all exacerbation in the LABA-LAMA treated group compared to LABA-ICS group. Can you please pick your choice? I know these are mouthfuls to read, but okay, so we can stop here for the sake of time. So about more than half of you are getting the answer correctly. So indeed, the FLAME study compared indacaterol, glycopyrronium versus salmeterol fluticasone. And when you look at exacerbation, which was the primary endpoint over 1 year, mind you, these patients had to have high risk of exacerbation. So they were in the severe category. There was 11% lower annual rate of all exacerbation with a LABA-LAMA versus a LABA-ICS, which was statistically significant and obviously clinically significant. However, when you look at the subgroup analysis, you can see that from this subgroup analysis that there was really not even one subgroup that was favoring a LABA-ICS versus a LABA-LAMA. However, in sub-analysis looking at patients with blood eosinophils, there was actually no trend of favoring, again, LABA-ICS versus a LABA-LAMA, as opposed to other studies which did. This is a Cochrane review, also published recently, suggested that when it comes to exacerbation, there is at least most of the study effect here comes from the FLAME study, as you see it, because it had the highest number of patients. So that analysis may be biased towards that study. But this is what the GOLD looked at. And the suggestion is LABA-LAMA have a better effect on LABA-ICS exacerbation from the published study, at least at that time. Now, of course, we learned a lot from the IMPACT study, which I know Dr. Sethi is going to discuss. Finally, what about de-escalation? This is something that GOLD suggests we do in patients who are stable on triple therapy. And can we do it? There are two large studies that looked at this. One is an older study called WISDOM, and actually the next one is the SUNSET study. I'll go through them very quickly since the time is running short. But the WISDOM study was looking at patients who were on tiotropium, salmeterol, and fluticasone at baseline. Now, mind you, some of these patients were not on triple therapy before they came in through the run-in, so they were put in on triple therapy. And then they did gradual reduction of fluticasone dose until off. And some group continued on tiotropium salmeterol, another group continued on triple therapy. It was a 1-year study. Patient population here were severe, that they had to have exacerbation in the past, at least 2. In the SUNSET design, it was a bit different. This was published just this year, where they looked at patients who had less or equal to 1 exacerbation the past year. But what is different here is they had to be on triple therapy for 6 months before the inclusion, but also they ran them in on tiotropium, salmeterol, fluticasone for 4 weeks before they got randomized to either the LABA-LAMA, indacaterol, indacaterol glycopyrrolate, or kept on the triple therapy. So there was an abrupt stop of inhaled corticosteroid. It was a shorter study because the endpoint was lung function between the 2 groups. So what happened? So this is one of the major differences which I mentioned earlier. Well, in the WISDOM trial, there was no difference between exacerbation, at least as you see here, over 1 year, between those who continued on triple therapy versus the LABA-LAMA patients. Now, in the lung function, there was some decline in lung function in patients who were taken off inhaled corticosteroid. A further analysis in this study suggests that those patients who have high baseline eosinophils tend to have the worst outcome, increased exacerbation and more decline in lung function. In the Sunset trial, which, as I mentioned, these are not high exacerbators, and it was a shorter-term study, the lung function difference was 26 ml, which really did not hit the predetermined difference, which was 50 ml. So it was a negative. It was non-inferior whether the patient continued on a LAMA or was put on LAMA or continued on triple therapy. And in fact, when you look at moderate severe exacerbation, there was really no difference between these two groups. Mind you, these patients are not high exacerbators. When they looked at the effect of eosinophils, there was a trend that patients with high eosinophil tend to have worse outcomes if they're taken off inhaled corticosteroid. And you can see that time to exacerbation here separates quickly in patients with high blood eosinophils, more than 300 compared to those who didn't. And similar finding was seen in the wisdom that I mentioned earlier. So maybe we can conclude that patients who are on triple therapy, who have high blood eosinophil, high exacerbation risk, we should not really be taking off their inhaled corticosteroid. And this is Peter Calvary wrote this. This is his opinion, but I support it. What he suggests that if you have a patient with triple therapy, you ask yourself, if this patient has an asthma component, or what we call ACO, we should not really go and take off inhaled corticosteroid. But if they're stable, and you can argue how do you define stability, but if they had no exacerbations and their blood eosinophils are not high, then those patients may come off inhaled corticosteroids, but you have to really monitor them. He suggests slowly stepping down to inhaled steroid. You know, the big question is, if a patient is on triple therapy and fixed dose, how slow can you go? It's really hard. It's not practical. And then, again, the Sunset study did an abrupt withdrawal, and it seems like most patients in that moderate type of patient severity did well. So what about, just final slide, what about safety? We always worry about adding 2 bronchodilators compared to 1. This is actually Sami Suissa's data. Of course, it's observational, but they're large databases. He suggests that patients who were started on combination therapy versus monotherapy, looking at cardiovascular endpoints, as you see here, the biggest concern was for him is heart failure was higher. The odds ratio was slightly higher compared to the monotherapy. But all other cardiovascular endpoints were similar. What about from clinical trials? Mario Cazzola's group published this meta-analysis looking at cardiovascular endpoint with different LAMAs, and the conclusion that they came to that there was really no increased cardiovascular risk factor with a LAMA versus a monotherapy with long-acting bronchodilators. So to summarize, there is a strong pharmacologic rationale of adding 2 bronchodilators with 2 mechanisms of action. There actually may be a beneficial effect and a synergistic effect, although this needs to be looked at more in improving lung function, improving exercise tolerance, reducing symptoms, and possibly reducing exacerbations, although this has not been shown in large, huge studies. I think monotherapy is still very appropriate for patients who have controlled disease with just 1 bronchodilator. And again, what we also can conclude is some patients on triple therapy may be successfully taken off inhaled steroid, especially if they're not at risk of exacerbation and have low blood eosinophils. Thank you very much for your attention.
Thanks, Nick, for a very comprehensive review and good timing. Our next speaker is Dr. Sanjay Sethi, and he's going to discuss triple therapy.
Yeah, thanks, Dan, for this invitation to speak and the wonderful turnout. So I'm going to talk about triple therapy, and that was the title I was given. And here are my disclosures, some of which are relevant. So the question I'm going to ask is, the 4 questions I'm going to try to answer. What is triple therapy in COPD? Why triple therapy? and then actually raise some unanswered questions and concerns that I have, and then give you my personal approach to dealing with this issue. So triple therapy, of course, we all want to think of it as LAMA-LABA ICS, and that's frankly what I'll focus on. But there are alternatives. So for example, you could add a phosphodiesterase inhibitor to a LAMA-LABA. You could add a macrolide to a LAMA-LABA. And we were hoping we'll add a biologic, but that's not happening anytime soon. So those are all options that we could have had in terms of triple therapy. So as I said, we're going to talk about this because frankly, that is the one which we do every day, and good reason, because though phosphodiesterase inhibitors are effective, we all are very familiar with the issues of tolerance. So I think I use that as I'll show you my algorithm. If this was a better tolerated drug, we would be talking about it, I think, in comparison to ICS. With macrolide, my concerns, and as you would see about how we changed in terms of antibiotic resistance and in terms of long-term efficacy, there are some concerns. So I think, again, this would not be my triple therapy choice. And as I mentioned, there have been inconsistent results with the anti-eosinophil medications, and we would all love to have another real biologic which is meant for COPD, hopefully in the future. So why triple therapy? So you can think, if you look again at the GOLD guidelines, there could be two reasons why you would consider using triple therapy. One is to reduce exacerbations. And so let's do a question. Which of these interventions reduce exacerbations of COPD? A short-term smoking cessation, regular use of a short-acting beta agonist like albuterol, pulmonary rehab, use of a mucolytic like guaifenesin. So go ahead and answer that. All right, I think we're pretty much on the right track. So it is pulmonary rehab, which is effective. So I think SABA is about the only drugs which have not been shown. In fact, that's the comparator arm in every exacerbation reduction study. Interestingly, short-term smoking cessation, there's not good evidence. You need long-term smoking cessation to reduce exacerbations. And mucolytics, again, there is no evidence that it works. So in terms of exacerbation prevention, so obviously triple therapy, that's one indication to go to triple therapy. The question is, how do we define which of those patients? Again, most COPD patients will have exacerbations. And it's obviously we can't use just lung function. So even if you look, this is from the ECLIPSE data, even if you look at people up here with very severe COPD, look at the reverse part of the graph, that is, more than half are not frequent exacerbators. So you just can't use FEV1 as a criteria. So the criteria we want to use is frequent exacerbator, which means 2 or more exacerbations over the past 12 months, or now we're talking about, because hospitalization for an exacerbation is such a significant event, that's also become now a criteria to go to triple therapy. So basically we're talking about groups C and D, mainly D because C is relatively small. So that would be definitely an indication to reduce exacerbations. I think over the last few years, we have become so focused on exacerbations, we actually have forgotten something, that steroids have another mechanism of action, another benefit in COPD, which is they reduce symptoms and can improve, to some extent, quality of life. So I go back to rather old evidence for this, and this is a study of budesonide formoterol versus formoterol alone. This is the registration study for budesonide formoterol, and you can see they use a very nice tool, the BCSS, a well-validated tool to assess daily symptoms. And you can see that addition of budesonide reduced symptoms significantly in these patients. And a good measure of that is how often do they use the rescue albuterol. And you can see, again, the addition of an inhaled steroid reduces symptomatology in COPD. So let's look at the evidence for triple therapy. Now, I don't have time to go through all the studies which have come out. So I'm just going to talk about the IMPACT study, not because of any bias, it's just because of time issues, and of course, it is the largest and well-done study. But before I go there, I thought I could summarize all the triple therapy and all in COPD by couple of very simple equations. So one equation is that 3 is better than 2 and then better than 1. I mean, that's the bottom line. I mean, you look at every study, and if you add another one like 4 on top, the same thing happens. You'll always get benefit. But, and there's a but to it, and that's 1 + 1 is usually less than 2. and 1 plus 1 plus 1 is usually less than 3. The point is the benefit is incremental. You're going to get your biggest bang for the buck with your first medication in COPD. Everything else will add on to it, and I'll show you data for that. So let's talk about triple therapy and exacerbation frequency. And again, as I mentioned, I'll just talk about the impact study. You must be all familiar with it. So large study, triple therapy versus a LABA ACS and a LAMA-LABA. Again, a well done large study. And let's look at the results. And what we find is for exacerbation frequency, the triple therapy does better than dual. But in this case, the LABA ICS does better than LAMA-LABA. So I think that question is now again up in the air and needs to be resolved. And you can see the curves here in terms of time to first analysis. So clearly, triple therapy reduces exacerbations on top of dual therapy. How about symptom burden and functional limitations? Again, looking at the impact data, I'll just want you to focus on St. George's scores. And you can see that there is a larger difference. So you get a larger difference with the triple therapy versus the duals. But I think the better way to look at that is the responder analysis. And you can see there's significantly about 8% more people who got a significant change in the St. George's Respiratory Questionnaire. So yes, triple therapy at the addition of an ICS improves quality of life and reduces symptom burden. So the next question now is, who do we do it? Why don't we just do it for everyone? You know, that's kind of the philosophy some people have. And because it's not a pro-con debate, I thought I'll debate with myself. So in terms of the pro, so the evidence says, yes, 3 does better than 2, you know, and so why wouldn't I do triple for everyone? There is, in the impact study, a potential reduction in mortality. Maybe that should be in the back of my mind. It is the best therapy possible, you know, so why not give my patients the best therapy possible? And if an open triple is required, closed triple is better because you automatically get better adherence. You know, they're not taking one inhaler and not taking the other, and you also get a single copay in most situations. So that last point I would not argue against myself. I think that's a very valid point. We should be considering that. The con is that you're only getting incremental benefit. So if you go from 2 to 3, you're only getting incremental benefit. And I would say that yes, there's a potential reduction, but it's not definitive. So to me, I don't think I can tell my patient with full assurance that I'm going to, you know, make you live longer if I give you triple versus dual therapy. And the other problem is if you give the best therapy right away, then you've got a problem with patient expectations. You know, I've always found that to be a problem. So you've got to keep that in mind. Cost can be an issue that has to be kept in mind. Triple therapy usually will cost more. And I think if this came without any increase in adverse effects, you know, for me, that's the most valid point, that you do have an element of increased adverse effects. And I'll talk a little bit about pneumonia. And there are other inhaled steroids. We all dealt with it, thrush and skin bruising and other things that happen. So that has to be taken into account in your decision making. And another point, which I think somehow don't, even I just kind of recognize it while I was arguing with myself, is if you start with triple therapy right away, we are ignoring the dynamic nature of COPD, and I'll talk about that a little bit more. But let's do the second question. It's a bit of a trick question, so read it carefully. The incidence of pneumonia in COPD patients on inhaled steroids compared to individuals without COPD is increased by 2-fold, 10-fold, 20-fold, 40-fold.
It's a tough one.
So let's have some votes. All right, I got you. My question was compared to individuals without COPD. So COPD itself gives you a 10-fold increased risk. So actually the answer is 20-fold. So if you take a general population, the incidence of pneumonia is about 0.3 per 100, whatever, and 0.3%. It goes up to 3% if you just have COPD, and then you add ICS, it goes up to 6%. So that's the idea. So that's why, but the actual risk of the inhaled steroid is twofold, but that still is a risk. And clearly, and that is reflected in this meta-analysis, as you can see at the bottom, the relative risk of pneumonia, again, is about half. So again, the twofold formula works if you compare a LAMA-LABA versus a LABA-ICS. The other point I wanted to bring up was that COPD is a dynamic condition, and I'm sure as all of you as practitioners have seen that. Your patients come in terrible shape, a lot of exacerbations. You start managing them, and things change. COPD is not static. We always talk about the frequent exacerbator phenotype, again, based on the ECLIPSE study, where the red bar are the frequent exacerbators, and as you can see, they tend to remain frequently exacerbating. But if you look at it carefully, the positive predictive value of a frequent exacerbator phenotype, which means that in the first year, if they had 2 or more exacerbations, the positive predictive value for the next year is only 55 to 60%. So it's not a perfect phenotype or not a consistent phenotype. The second thing is people change lifestyles. We try very hard, but smoking habits change, environmental exposures change. You could be dealing with the comorbidities and treating them better. You may put them through rehab, they may become more adherent to the treatment. All of this can change exacerbation frequency. So I think if you start off with triple therapy based on high exacerbation frequency, you have not given your chance for double therapy to work, or even whatever you decide initially to work before you jump onto triple right away because of this dynamics. All right, so that's let me just move on to this, another 4 interesting topics for me. I'll just summarize them really quickly. The first one is impact on the lung microbiome, and that to me is another concern that we should be thinking about. We should talk about blood eosinophils. It was mentioned already. There are a lot of problems with symptom exacerbation assessment and what to do with unreported exacerbations. So, the lung microbiome, that's been my favorite topic of research for many years and clearly plays a significant role in COPD. So our healthy lung has got a very transient microbiome, but then because of changes in regional growth conditions, you end up with a rather unhealthy microbiome in the lung in COPD, which contributes to the disease. I think we all agree on that. But we can also change the regional growth conditions because of our treatment. So we've got to keep that in mind. And what we don't want to do is to take our normal microbial residence status, which is of a tourist visa, to give them a green card, or versus to make them a citizen, and then they want to kick everybody else out. So that's a concern, and that's what exactly happens as the microbiome changes in COPD. And there is a nice study that just came out. This is from Alberto Papi's group, where they took 60 patients with COPD, steroid naive, so that was good. 1-to-1 randomization to salmeterol or fluticasone salmeterol. The fluticasone is at the higher dose because it's a European study, and essentially showed that after 1 year, the inhaled steroids, so this is the bacterial load, or the amount of bacteria, so that goes up in the salmeterol-fluticasone combination, but not in the salmeterol group. But to me, what was more worrisome was it's kind of small and difficult to read, but we're looking at the major pathogens actually these 3 are major pathogens: Streptococcus pneumoniae, Moraxella catarrhalis, Haemophilus influenza, Moraxella catarrhalis. All of them tend to go up with inhaled steroid use. The one that goes down is Prevotella, but Prevotella is something that you may want in your airways because it's not that damaging to the lungs. There's also some other changes: increased alpha diversity, which means there are more variety of bacteria in your lung with inhaled steroids, and increased in Firmicutes, which interestingly the Streptococcus belongs to, so that phyla. So that's worrisome. How about eosinophils? To me, this is more of an unanswered question. I think we need more data. And, because one of the issues we presented at ATS last year, there's baseline variability, which, people change their eosinophils. So I think one value is not enough. But, and we talked about how ICS could be beneficial, but there's also some suggestion in the data that if you have low eosinophils, in fact, ICS could be potentially harmful. So again, but I want to just put this in the end. In my mind, based on what I've seen, this is going to be like a D dimer. It's not going to be a CT angio. It's not going to be definitive. It's going to help you in your decision making. You can't just take this one value and make a decision on your treatment. So, but use it. I think it's still useful. So the next 2 are kind of concerns I have. One is, we have based so much on our patient assessment of exacerbations and symptoms. If you look at the whole paradigm of COPD management, that's all we are supposed to do now. So this is was presented last year. I haven't seen it published, from Fernando Martinez and Byron Tomashaw. They did a survey of 10 pulmonologists. I hope none of you were in this, and 7 primary cares and 40 patients. And what they found was these wonderful questionnaires we all advocate to categorize our patients. About 6% of them were using it. Spirometry was done in about a third of patients, and exacerbations were underestimated. So when they asked the patients about, by their estimate, 60% were frequent exacerbators, by the physician estimate, about only a third. Another study is a study of 15 practices which do spirometry on a regular basis. I'm not sure whether these were primary care, I don't remember the details, but the bottom line is only 60% of the spirometries met ATS criteria of acceptability. So garbage in, garbage out, you're making decisions based on not good data. And then, when I've interacted quite a bit with primary care, and, the problems are in their assessments, hopefully, and definitely not in pulmonologist assessment, I'm sure, is they emphasize dyspnea rather than exercise tolerance. For them, an exacerbation makes a person an exacerbator. There is a lack of distinction between frequent and infrequent exacerbators. Comorbidities can cause similar symptoms, so we are basing it all on symptoms, and as I mentioned about spirometry, that can be misleading. So these are challenges that we need to overcome or develop more objective assessments in COPD. And then the last concern I have is what to do with unreported exacerbations. So there are multiple studies showing that this is one of the studies showing that as many as 2/3 of exacerbations in COPD go unreported. And they're not always necessarily milder, it's just that patients sit at home and deal with it. And the bottom line, and here as shown in this particular study, the ones who had unreported exacerbations, their St. George's went up, which is within 3 months, almost as much as the ones with reported exacerbations. So going up is bad with St. George's. So unreported exacerbations are bad. Should we count them? How do we count them? We don't know as yet. Another question in my mind. So let me just finish up by saying what I do. If I have a patient of mine who I don't have inadequate control, of course, you've got to start with smoking cessation. Assess inhaler technique. Assess adherence. These are big issues in COPD. Check their vaccination status. Assess their comorbidities and make sure one of those is not going back. If you luckily have rehab available, definitely offer it. And then in terms of pharmacological management, if you have done all that and you're sure that you want to intensify therapy, of course, after you have maximized your bronchodilation, you institute triple therapy. So I would still say in these situations, if you have done all this, you should be using triple therapy. That doesn't work if they have chronic bronchitis. What I do is add a phosphodiesterase inhibitor. If that doesn't work, either add or substitute chronic azithromycin, or they can't tolerate the phosphodiesterase 4 inhibitor. And these are all kind of not definitive, but these are the other things I might consider. And I'm telling you, Dr. Mala didn't pay me to say that, but consider adding nebulized bronchodilators. I do that sometimes. I haven't put low peak inspiratory flow into our practice, but we plan to introduce that. We did a study with pulse moxifloxacin. I've done that in a couple of patients. It's known as a pulse study. So if your azithromycin doesn't work, if now good data for hypercarbic patients, you could do proper non-invasive ventilation, not just slap them on to 12 and 6. Anti-eosinophil biologics, that's a big question mark. If I have clearly well-defined asthma COPD overlap, not because the patient said I have asthma, then I would consider that if the eosinophils are high. And if you want to get rid of the patient faster, put them on oral steroids. So that's all I have, and thank you.
Thanks, Sanjay, for an excellent review. So I'm going to talk about when to prescribe nebulized bronchodilators in COPD, and I'm going to start by informing you that this is a data-poor area. Again, when I did training and when I've talked to fellows, residents, it's very subjective how and when we use nebulized therapy. And I'll try to review what's in the literature and then, again, mention it's a wide open area for investigation. Here's my conflicts of interest slide. Remind you that we have 4 different delivery systems available. You're all familiar with this. The MDI was first developed in the mid-1950s and nebulizer 1964. So these go way back. So precision medicine is one of the buzz phrases. what's effective for the individual patient based on genetic, environmental, and lifestyle factors. First question. In my practice, not my practice, in your practice, I use nebulized therapy primarily in two situations. Patients with asthma and COPD hospitalized for an exacerbation and end-stage COPD. True or false? Okay, so more people said true, but quite a number said false. I'd like to review with you a survey that Sid Brayman is the first author on. Maybe some of you participated in this. At the bottom, you can see this was an online survey of 205 pulmonologists and fellows through the Chest Foundation coordination. And the question was perceived effectiveness by pulmonologists based on the modified MRC scale. And if MDIs and DPIs were perceived more effective, you see it on the left. If small volume nebulizers were perceived as being more effective, we see it on the right. These numbers don't add up to 100 because some people said it seems about the same, equal. And as you can see, as shortness of breath gets worse, the perceived effectiveness increased with nebulizer use. And this is grade 3 MRC scale, stops for breath after walking about 100 yards or after a few minutes on the level. So again, based on a survey, and again, I think that's probably as representative as any information we have, once you reach this level, the general perception is nebulized therapy seems to be more effective than handheld devices. So I'd like to remind you that at the present time, we have all the same medications available same classes of medications available with the nebulizer as with handheld devices. Obviously, we don't have the combinations available that are in MDIs or DPIs or SMIs, but we have the same classes. So, if you were to ask me, what's the best evidence if I wanted to look something up when I get home? Dr. Bob Wise and a panel of experts published guiding principles of nebulized bronchodilator therapy in the Journal of COPD Foundation last year. And again, they tried to evaluate, analyze published information, and then it's really more of an expert opinion. So I'm going to show you the indications that they came up with. Laryngectomy present, patient returning home or from a long-term care facility from recent hospitalization and nebulizers available. The patient prefers nebulization. Maybe they had it in the hospital, maybe they got it in the ED, thought, hey, this is really good. Cannot afford handheld devices. I think this is a changing topic, but certainly in many situations, Part B Medicare frequently covers most or all of the cost of nebulized medications. Cognitive or physical impairment, that is, maybe somebody's frail, has difficulty with coordination, that may require a caregiver or a family member or a spouse or significant other to prepare the nebulizer itself. And then I'm going to spend the rest of my talk on these last two indications. Persistent or unstable symptoms, history of frequent exacerbations, hospitalizations, despite the use of handheld medication. And then they also added low peak inspiratory flow rate, unable to inhale powder deep into the lungs. So first one I'm going to cover is persistent or unstable symptoms. And we're all familiar with the tracheobronchial tree and where smooth muscle is located and the different receptors that we have in bronchial smooth muscle. And we recognize that optimal delivery into the lower respiratory tract is important. And use of handheld devices, there's at least four important characteristics. What is the inspiratory flow? Even with MDIs and soft mist inhalers, there's an ideal inspiratory flow, which is generally low, to inhale the medicine appropriately. How long you hold your breath. The time of actuation, key. And then the breath hold. And now these things may seem simple to us, but patients may not find this so simple. I think we all have experiences that this can be challenging for some of our patients. Let's look at errors in PMDI use. Sanchez did an interesting publication in 2016 in Chest, and they reviewed, you can see at the bottom, 144 articles on inhalation technique that included over 54,000 patients. So again, they're reviewing what's published. And in the publications, the three most common errors with PMDI use was poor actuation coordination, almost half, improper speed and or depth of inhalation. But what does that mean? If in the studies that measured inspiratory flow, if it was above 90 liters a minute, that was considered too fast for optimal delivery of the aerosol from the MDI. And then no breath hold. So you can see even in, quote, academic centers that are publishing this material, there's huge challenges with MDI use. And interestingly, they looked at the time period. This started, it's a 40-year period they looked at. The last 20 years, the same errors occurred as in the first 20 years based on the date of the publication. Let me just show you a study on a small number of subjects published 13 years ago, which emphasizes the importance of inspiratory flow for meter dose inhalers. So at the top is total lung deposition. And the white bars, the patients used a slow inspiratory flow rate on average of 31 liters a minute. And then the F fast was 67 liters a minute. And you can see here at the top, S and F, and the size of the aerosol particle. And you can see better lung deposition with a slower inspiratory flow rate, around 30, compared with a flow rate a little over 60. And then at the bottom here is the delta change of FEV1. Again, if we look at 3 and 6 micron size, you can see not only better deposition, but better bronchodilation with this slow, low inspiratory flow rate. And again, that's something I think most of us don't focus on. There are some tools or appliances we can add to the MDI. I'm not going to discuss those this morning. So let's look at peak inspiratory flow rate. And this really applies to dry powder inhalers. And the second question I have for you is, the 2018 Global Initiative for Chronic Obstructive Lung Disease, GOLD, recommends measuring peak inspiratory flow rate before prescribing a dry powder inhaler. True or false? GOLD recommends measuring PIFR if you're thinking about a DPI. So it's about 1/3, 2/3. So the correct answer is false. GOLD does not recommend it, doesn't even talk about PIFR. Whether they will develop this, again, it's an emerging topic. I'll try to review briefly with you. So we have 5 different dry powder bronchodilators approved in the United States. There's another one with an inhaled corticosteroid, the Turbuhaler, but that is not a bronchodilator, not approved for use in COPD. And what's unique about DPIs are 2 things. They're breath actuated, right? You have to initiate the breath to inhale the powder. And each of these dry powder inhalers has an internal resistance. And Sanchez, in this article I showed you about errors in MDIs, looked at the published studies with errors in DPIs, incorrect preparation. Now, that seems pretty simple to me, and I'm assuming to many of you, but people didn't press the lever or pull down the cover or put the capsule in the right spot. Not exhaling completely before inhaling, 46, and no breath hold, 37%. So again, there's challenges with use of DPIs. And principles of drug deposition from DPIs, I show a picture here of the discus. And I think we all recognize that at the bottom here is the coil with these little gumdrop black objects, which is each of the powdered medication. And by pressing the lever, these rotate up, and the powder is deposited right here. And then we have the resistance above it, including the mouthpiece. So the principles are that you need turbulent energy to deaggregate the particles during inhalation. And that happens inside the DPI. So basically, you're breaking up that clump of powder into small particles. This is determined by inspiratory flow rate and the resistance of the DPI. And then patients should be instructed to inhale forcibly from the beginning of inhalation. And this is an ERS ISAM task force published in ERJ in 2011. These are their recommendations. So we're going to talk a little bit about inspiratory flow rate. Here is a commonly used measurement, the in-check dial. I have no financial interest in Clark Clement, which makes this. This has been widely used in clinical trials that have been published to date. And if we look at the dial here, you can see there's an opening there in the top right, and you rotate the dial and to the appropriate size of the opening. And you have, in the original in-check dial, you have a resistance corresponding to the discus, top left, to the turbuhaler, lower left, and then you can add an appliance on to simulate the handihaler resistance. So this is a way to check the inspiratory flow rate, again, simulating the resistance of the different DPIs if you're interested to see, does the patient have an adequate inspiratory flow? And based on published studies, the general conception is that you need a peak inspiratory flow rate of 60 or liter to have optimal delivery and turbulent energy. And if it's less than 30, it's insufficient. And based on, again, these three references as well as some others, it's kind of 30 to 60 is some benefit, but we don't know exactly how much benefit. And again, this can vary, but that's the general understanding at the present time. I'd like to show you briefly an in vitro study performed in Japan. And what they did was they tried to simulate in the laboratory what would happen with a patient. So here you have the device that was used, that was placed, and they used fluticasone powder discaler. So they basically put it in there, and then you can see over here to the left a vacuum pump. So they could adjust the vacuum pump at different inspiratory flow rates, and they could measure the amount of powder in the throat here at the top, in this stage 1, which is a larger airways, and then they called this stage 2, this flask, which they considered to represent what was in the lung. Okay? So they did different flow rates, they washed each of these 3 segments, and they measured the amount of powder based on different flow rates. So here's what they found. The amount of drug deposition is on the vertical axis, and the peak inspiratory flow is on the horizontal axis. And as you can see, this is a curvilinear relationship, and here is the line for 30, and the corresponding amount of drug deposited in this beaker, which was representing the lower respiratory tract. And here you have 60, and then you have the corresponding drug deposition. So this is one of the references that I think has potential application. Again, it's an in vitro study. We don't have exact data like this in humans, but it seems like a reasonable model. So Al Shawar was one of the first authors to look at peak inspiratory flow rate through meter dose inhaler here on the left, the discus device, the turbulator device, and the HandiHaler device. And you can see different levels here, the different bars, different severity of COPD. So first thing you notice is, again, patients were instructed to inhale as deep and as hard as possible. And you can see with the MDI, which has basically minimal resistance, peak inspiratory flow rates were quite high, higher than desired. And I show here the line of 60, and you can see as there's increase in internal resistance. The discus is considered low-medium, the turbulator has a higher resistance, and of the available DPIs, the HandiHaler has the highest internal resistance. So as you increase the resistance, the peak inspiratory flow rate is diminished. And this is the percentage of patients who were below 60. So you went from the discus 53% up to 100% of these patients, 163 patients, that were tested with the HandiHaler. So what is the prevalence of a PIFR less than 60 in COPD outpatients? Basically, the discus and the HandiHaler, widely used, are the data that we have available. And in 3 studies, the range was from 19 to 53%, below 60. Different studies, different populations. And for the 2 studies with the HandiHaler, all of the patients. So here's an X-ray, which you're all familiar with, hyperinflation. If inspiratory flow rate depends on respiratory muscle strength, I would say this is a type of patient who has flattened diaphragm from hyperinflation. It's going to be difficult for this type of patient to generate an adequate inspiratory flow because the diaphragm is at a disadvantaged position, length tension. So alternatives, which you're familiar with. So advantages of nebulized bronchodilator therapy, study published by Don. Minimal coordination and effort required, normal tidal breathing, similar medications as with handheld, and usually covered by insurance. The disadvantages require external power source and time, preparation, delivery of dose. So Dr. Wise, in summary, and his group recommended to assess nebulized bronchodilator therapy, either you in your practice or in your hospital, consider 3 things. Assess manual dexterity. Again, you can do that formally, you can talk to the patient, you can give them a sample or a placebo device, see how they handle it. Evaluate cognitive ability and vision. And then measure peak inspiratory flow rate relative to DPI. So I'm going to stop there. We do have time for questions, comments. Please use the microphone in the center of the room. We have about 6 minutes. And if you have a question, address it to either one of the presenters or to all of us.
Hi, thank you for the talk. What do you recommend in ventilated patients
As far as medications,
as far as inhalers versus nebulizers?
I'm not aware of a study. Nick, do you have information?
There are no formal studies, but you can use an inline with the ventilator tube and use MDIs. But in our institution, we use nebulization. Whether one is better than the other, it's, there's really no good data comparing one with, but you can use either. Dry powder are a bit tricky, in ventilated patients, but definitely aerosol, like through inline, there is an adapter that you can use, and you can give, but you have to give usually a larger dose than 2 puffs of albuterol.
When I worked at Dartmouth-Hitchcock, they used MDIs, and the respiratory therapist would try to coordinate the timing of actuating the MDI when the inspiration was delivered by the ventilator. But again, wide open for investigation. I'm going to guess if you did a comparative study with the same types of medicines, you're probably not going to find any difference. That's just a guess on my part.
Got it. Thanks.
Tom Seiler, St. Charles, Missouri. I just had a comment on Dr. Sethi's talk. With the impact study, it's important that everybody remembers this data is only applicable to frequent exacerbator phenotype. My concern in general usage and what's happened with open triple is that there's a lot of patients that have never had an exacerbation, don't have elevated eosinophil counts, and they're on triple therapy, which probably there's no data to support that use.
Tom, yeah, I mean, your point is well taken, but one of the studies that was not presented here was presented at ERS, and it's now in Lancet, is the Chronos study, which looked at triple therapy in actually non-exacerbator, which was interesting because the purpose was to look at lung function effect, and they did achieve a lung function benefit with triple therapy. But the secondary endpoint was exacerbation, and surprisingly, the exacerbation rate in that non-exacerbator group was significantly lower with triple versus LABA/LAMA. Now, obviously, a large one-year study with this new formulation is being done. We don't have the results yet, and also surprisingly that the pneumonia incidence, even though it was a 6-month study, was not seen.
Right.
So whether this is, again, a formulation issue, obviously in impact, pneumonia was seen about 8% and higher than the LABA/LAMAs. But we need to see more because, as you know, there are 3 formulations of triple therapy being looked at, and 2 are already approved, one in the UK, one in Europe, one is here, and the third one is still in phase 3 trials.
Yeah, in Chronos, there was a difference, but the number of exacerbations was quite small overall because it wasn't an exacerbation-rich population.
And Tom, I mean, I just, I agree with what you're saying. I mean, the problem is that there's still a lot of LABA/ICS used as initial therapy in COPD. And that's why we end up with, I think that's part of the reason we end up with people on triples,
That
because the
LAMA.
LAMA, especially open triples, because they start with LABA/ICS. And that's the thing, one thing we need to change.
Yes.
You know, unless you have clear-cut overlap with asthma, you should not be doing that, in my opinion.
Thank you.
Alec Platt, I'm from upstate New York. I have 2 questions. One is there any data to suggest that it matters whether somebody's on a dry powder inhaled corticosteroid versus a non-powder inhaled corticosteroids in terms of risk of pneumonia or exacerbation rates, number 1. And number 2, with regard to the issue of nebulization versus handheld inhalers, none of the, there wasn't really any outcome data that was discussed in all these studies that we reviewed here. We're not presumably stratifying patients according to peak inspiratory flow. So I would ask how you would respond to sort of that question of if this is such an important issue, why are we not seeing this data from the trials?
So I'll ask Sanjay to do the first, and I'll take the second.
Yeah, so the first one, there's no data that it makes a difference. And I think, there may be some differences in steroids that may be somewhat dependent on steroid dose, but the bottom line is, you clearly, for example, you don't see a clear-cut signal in asthma. I think it's something to do with the disease, the local milieu in COPD, which is already colonized, and then you make that worse. So I think I would be worried, and I would be surprised if nebulized steroids have less of a signal.
So the second question, outcomes, yes, I did not show any limited data. We have published a study in 20 subjects, single dose of salmeterol discus versus arformoterol nebulization. 2 different drugs, both LABAs, both have peak effect at 2 hours. We recruited people who had PIFRs less than 60 on 2 separate occasions, and we found a significantly better improvement in FVC and IC at 2 hours with nebulization compared with dry powder. And changes in FEV1 at that time were similar. So we had a volume response. Again, small numbers of subjects. People who received the salmeterol via discus improved, but not as much. Secondly, there's a poster which is up now, which I'm presenting tomorrow, which is a multi-center RCT comparing a nebulized LAMA, not yet approved in U.S., and tiotropium via HandiHaler. And in the patients who had FEV1s less than 50% of predicted, and again, all patients had PIFRs less than 60, there was a greater improvement in trough FEV1 by 49 mLs compared with tiotropium via hand inhaler. So that's not published, but presented tomorrow.
Thank you.
Sure. Last question, and then we'll close up.
Excellent talk. I just want to add one question with Dr. Sethi. I think in one of his slides, he mentioned the use of azithromycin in these patients with severe COPD, and I've kind of debated, in which patients to give this to, and with the exacerbators, the monitoring, and just wanted to see what your thoughts were on that. And I'm not aware of any recent data, but if you could enlighten us with that.
So, after the big macro study, clearly it works, reduction by the magic 25%, which all the drugs seem to do. So it's about 25% reduction from the big macrolide study. They use azithromycin. So I do it in the context of, as I mentioned, with LABA, LAMA, ICS. My usual go-to is roflumilast unless it's not tolerated or is not, and then I would consider using chronic azithromycin. The one more study that has come out after that was is more of a observational follow-up over 2 or 3 years. And what's interesting is if you look at the study, I was one of the reviewers, and though they say nothing changes, you can see that there is some subtle loss of effect, and there's some emergence of more resistant organisms. So that's why for me, that's a fourth-line drug, but in the right population, it works. It has benefit. I tend to use 250 milligram 3 times a week because that works in CF. Why do we need 500 milligram 3 times a week? If somebody's very obese, I might go to the higher dose, but otherwise not. So yeah, I have a few patients on it, and you will see patients who will clearly benefit. And it's actually mainly an antimicrobial effect. We have some data for that.
Great if you,
Yeah, you get a reduction in exacerbation. That's what you're mainly looking for. It doesn't improve symptoms dramatically. Oh, that's the problem. The study's for 1 year, so I tend to continue for at least a year. If they do well with it, you may consider giving them a drug holiday, especially over the summers if they don't have, if they have a seasonal pattern. But I've had patients now, some of them, a couple of years, they're still going on with it.
so it looks like nobody's wants to enter the room for a new session, so as long as people are here, no, there's nobody.
I'm wondering about
Go ahead, please.
the cost of the inhaled corticosteroids. I've been doing this work for 40 years, and in the beginning we had inhaled steroids that were not that expensive, but now all of them are, if you have to pay out of pocket in the United States, $300 a month or more.
That's unfortunately a true fact. We're hoping that one of the several generics being studied will be approved and may have the ability of cutting down the cost. So stay tuned. There are several being looked at. I'm hoping, again, that the cost will be less prohibitive, but I totally agree with you.
It almost seems to me like it's collusion in the industry.
If you have additional questions, come up front.
Yes, I will do this.
It doesn't depend on your participation.
No, I know, but does it have your name on it?
It has my name, and we can do check.
I'll send it. And now, especially with the implied contributing $1 billion, willing to match $1 billion, that's great.
We'll match.
You'll match it. I was there. Yeah, I know. Sorry.
Would you have one of us? Where was it published? Mayo Clinic Proceedings?
I said that, the overall, I think that way there's
67 people, they added a llama to the.
So that's an epidemiological study.
observation. But, in all the large animal substantially, a substantial controlled, randomized controlled trials. And really, I think there's more cardiac similarities with the llama.
Who's adding a llama to the other?
Yeah.
Okay.
But there must be epidemiological, and then all the confounders in those studies.
And the other thing was, when you have a llama, do you still use samples?
Great question.
The official answer is no, but patients have their Combivent inhalers and they use them.